Dear Lord, thank you so much for bringing us here this evening. Father, we realize that the virus has become a very divisive issue in families as far as the vaccine is concerned. And I just pray that you will lead and guide. But for this evening, we want to understand more about the virus because there's so much that we don't understand. And so I pray that you will be with Dr. Chinonge and with us listening. Please give us wisdom, Father God, and help that we will understand, we will have knowledge that we can share with other people so that lives can be saved. This is my prayer in your loving name. Amen. So welcome once again, everyone. We are very blessed to have Dr. Kakeya Chinonge with us this evening. Now, Dr. Chinonge is a recently qualified specialist physician with an interest in ICU or intensive care units or critical care units, and these people work in ICUs. Often they do ventilation. You've heard a lot about ventilation now with this whole COVID thing. And he also has an interest in pulmonology, right? And that deals with diseases involving the respiratory tract and lungs. And he's currently working in ICU at a tertiary hospital. And so, Dr. Chinonge, welcome. Thank you for being willing to share your knowledge with us so that we are empowered and so that we know what to anticipate when someone is in a hospital, because the sad thing now is that you can't go and visit your family members in a hospital. And very often, I think when people are so distressed, they don't understand what the medical staff is saying to them either. So we just want to learn so that Dr. Chinonge can educate us. And thank you so much. So over to you, Dr. Chinonge. Thanks so much.
Thanks for the opportunity to share what little. It feels like I know very little. I know, but I hope that, we can all learn something from it and grow from it. I think COVID has brought a lot of uncertainty, has brought a lot of mixed messaging. It's sometimes very difficult to understand what is the truth, what is the right direction to go. There are so many voices coming from different directions, and it can get cluttering a lot of the time. So I'm hoping that I can try and declutter some of the things. There's a lot that's out there, both in the mainstream, so like well-regarded scientific. There's a lot of information that's out there, and sometimes contradictory. It changes a lot, but also in the non-mainstream as well. There's just so much information. So we're going through really an information overload. So my talk today is gonna be very simple. I'm not going to try and give you too much. I'm just gonna try and help us understand the thinking process when trying to evaluate the information that we get, particularly scientific information. What's the thought process behind it? And that way we'll be able to try and understand in a particular way, I think, which is very important. Because as I engage with people, I realize that there's a lot of loopholes in their understanding of the scientific thinking behind things. So we're gonna just try and go through that kind of exercise. So I'm a physician. I'm a physician. So I specialize in internal medicine, which is essentially someone calls it the inside of the body, but it's adult medicine. Infectious diseases, chronic illnesses, so any adult medicine is what I've specialized in. So after 6 years of varsity, you do 2 years of internship, a year of ComServe, and then a medical officer time for about a year, and then 4 years of registrar time. And then you write an exit exam, and then you become a specialist. So I've gone through that process. I've been worked in the front line since COVID started. So I've got some experience in hospital, particularly. Seen a lot of patients. Currently working mainly in the ICU and high care, both at 2 tertiary institutions in Pretoria. So I'm trying to go to the next slide. So this is just a brief just outline of what we're going to be going through. We're going to look at the background of COVID, which I'm sure we're all familiar with, so I won't spend so much time there. We'll discuss about the virus itself. Okay, just sorry about that. Sorry, yeah. Then we'll discuss about the virus itself, and we'll discuss pre-hospital treatment, and then a little bit, I think this is mainly for non-medical people. So in hospital treatment, I'll just touch over, but if you have questions, I can answer that. And then just other considerations, just to think outside of the box and maybe where the world is heading in terms of the thought process around COVID. So this is a picture of Wuhan. At the end of 2019, a novel coronavirus was identified, which caused a cluster of pneumonias in Wuhan, in the city of, in the province of Hubei. And it rapidly spread, resulting in a global pandemic. It was, shocking to us all. I think a lot of us still can't believe what's going on. And sometimes you feel like you just wake up and it'll all have ended. It was designated COVID-19. So that stands for Coronavirus Disease 2019. That's the name of the disease once you're sick. But the virus that causes it is the SARS-CoV-2. So it's a severe acute respiratory syndrome coronavirus 2. I mean, what happened in Wuhan, that it was lockdown and 11 million people were staying in their homes, and we were just like wondering what's going on in China. Why does China always have these funny viruses? But eventually it made its way to us. Where did it really start? I think that's where a lot of people are stuck at. They want to know, but where is this thing coming from? So initially they're saying it was linked to pneumonias. The pneumonias were all linked to an area around a fish market in Wuhan, and they thought maybe it had jumped from bats to the fish, or from bats that were eaten, were the theories that are going around. The World Health Organization is also now investigating, trying to investigate, because they're getting a lot of resistance, particularly from China. The claims that the virus was actually leaked or released from a virology lab in Wuhan. So the Wuhan Institute of Virology. There's a suspicion that that is where the virus actually was being tested or was being formulated, and then was released into the world. If you know these two, you know them. So I put in a question mark, suspect number 1 and suspect number 2, Anthony Fauci and Bill Gates. I know there are a lot of people that put the blame at their feet. I don't know what evidence is there, but the blame is there at their feet. Could it be? Maybe not. Maybe they are to blame. Time will tell. But what we do know, as of this morning, August 12th, is that worldwide we've got over 205 million people that have been infected or affected by coronavirus. The deaths are sitting at 4 million. That's in the world. In South Africa itself, 2.5 million people have been infected, and we're sitting at 75,000, almost 76,000 deaths. So whether it's Fauci, whether it's Bill Gates, the fact of the matter is that coronavirus is here with us, and there are people that are dying from it. And I'm sure we all know somebody. a little bit about the virus itself. It spreads via respiratory particles from close range contacts, so 2 meters, and that's why the whole social distancing. There are some theories that it could be airborne. I know our professor in infectious diseases, who passed away sadly just when this was all starting, he was convinced before it even came to South Africa that it was airborne. And he kept on saying, this thing is airborne, this thing is airborne, watch it, this thing is airborne. So there are some studies that are looking into it possibly being airborne, but at the moment, it's not widely accepted that it's airborne. So it's spread via droplets. So when a person with the infection coughs, sneezes, or talks, then the virus is released. And then if it lands in your mucous membranes, then it will it binds to your ACE2 receptors in the airways via spike proteins, and that it enters the cell and then it starts replicating. So it's an RNA virus. So what are the symptoms? So that's coronavirus is just, yeah, it's got the scientific world in a spin. And it is evolving, it changes so rapidly. It's diverse in the way it manifests, so it doesn't manifest the same consistently. Like most other diseases do. It manifests differently. So there's some studies that look into what are the most common symptoms, and it's like almost each study has got different findings. So one study will say cough was the most common, and then another study will find that no, actually it was malaise. And another study says no, it was fever and chills. So it's not globally accepted or understood what the main symptoms are, but possibly some of the common symptoms. This is from the CDC. Some of the common symptoms are fever and chills. Sorry, I was just getting a call here. I am on call for a hospital, so just wanted to make sure. Yeah, it's nothing important. So fever and chills, cough, shortness of breath, fatigue, muscle or body aches, headache, loss of taste, loss of smell, sore throat, congestion. So you can have some of them, you can have a lot of them, you can have one of them. So it's very random. So some people it's just loss of smell and taste, and that's it. And for some people, just be the cough and the shortness of breath. So it's not specific, yeah. But we've tried to classify it into the severity of the disease. Not that this will tell us whether you'll survive or not. So just because you were mild at the start of your infection, it doesn't mean that you won't go on to become critical. But it's more just a red flag for the healthcare workers that are seeing you. So if you're severe, they know that they need to act and need to be monitored in a better setting than just being at home. So mild disease, someone who's got symptoms, meets the case definition, so it's tested positive, no evidence of pneumonia or hypoxia. So they've just gone mild. So it's like they've got a flu, typically managed at home. Moderate disease, clinical signs of pneumonia. So they're febrile, they're coughing, they're dyspneic. So dyspnea is shortness of breath. They're tachypneic, so they're breathing fast. And then their oxygen saturation. So the level of oxygen in the red blood cells is sitting above 90%, which is without oxygen, which is still acceptable. So they're not requiring oxygen. So these patients can typically also be managed in a home setting, but they just need to be watched a little closely because they are breathing fast, they are short of breath, and they can quickly go the other way. And then severe patients need to be managed in hospital. Reason being is that they need oxygen supplementation, and they're usually short of breath, quite short of breath. So the concern is that they can develop respiratory collapse, and then they'll need to be acted on quickly. So it's a mild, moderate to severe. Mild and moderate typically can be managed at home because they're not requiring of oxygen unless they've got other complications or organs that are involved. And then severe are usually managed in hospital requiring oxygen. So the disease process, this again is postulates. It's not that we know for sure, but what we think we understand about the virus is that it goes through this period, almost a 14-day period. Day 1 to day 5 is the incubation period. So you get exposure, and then you get infected, and then by about day 1, once you've gotten infected, to about day 5, day 3 to 5, you actually don't present with any symptoms, and the virus is basically replicating in your body, but the levels are so little that they're not causing you to be sick. Then from about day 5 to about day 10, you start to develop minor symptoms, the fever, the malaise, the cough, the headache, diarrhea. If you were to do a chest x-ray, there'd be maybe potentially mild infiltrates. And then as the disease process carries on, the virus itself is being destroyed, but there are particles that remain. This causes an inflammatory response in your body, which soon starts after day 11. And it's this dysregulated response, inflammatory response. So your body just, goes into overdrive and fighting what it perceives to be a foreign body. And as it goes into overdrive, it starts damaging yourself. And yeah, that's basically what happens with COVID, and how patients then develop what they call ARDS, or acute lung injury. So that's the early pulmonary phase, and then you get the late pulmonary phase where they start to settle, and we don't think it's well, not really settle, but more of the destruction takes place. Yeah, so that's roughly it. So day 1 to 5, asymptomatic. Then from about day 6 to 11, you start to develop symptoms, and then day 11 to 14, you'll basically know whether you're going to be in hospital or not. So then about day 14, if you're safe, nothing's really happened to you, then yeah, you're less likely to develop complications. Not complications, but pulmonary disease, rather. Let me put it that way. Yeah, so that's about it from this slide. I'll come back to it. It's important in terms of the treatment as well. So pre-hospital management. So what's the equipment that you'll need at home? Basically, you'll need isolation space. So either part of the house, or a room or flat in the house, where you can isolate, so that those who live with you won't be exposed overly. They will be exposed to some extent. You'll need gloves, that whoever's helping you, taking out your cutlery and stuff from the room, is protected. You'll need a thermometer to measure your temperature. When you need to break it, you'll need a pulse oximeter. That's vital in the whole process. But even they have got issues, so they're not 100% reliable, because they can have battery issues, calibration issues, depending on the quality you buy and things like that. But it's better than nothing. So a pulse oximeter, so that basically measures the oxygen level. It's difficult for you as an individual to tell when your oxygen levels are low, particularly with COVID. So in many other diseases, you'll be able to say, look, my oxygen levels are low, I'm feeling dizzy, I'm feeling short of breath. But with COVID, there's something called the happy hypoxic. So oxygen levels are low, but this person looks like they're not suffocating, or they're not really that much struggling. Obviously, they are tachypneic, so they're breathing fast. And as a healthcare worker, you can notice it. But sometimes, as a layperson, you don't pick up that this person is actually breathing very fast. But when often when patients then arrive, saturation is sitting at like 30, 40%, and you're wondering, but how did they manage all this time for maybe 3-4 days with oxygen levels below 80? But somehow, yeah, I've seen the lowest was like 20-something%. Comes pushed into the emergency department, tongue is blue and breathing like crazy. But the family just didn't notice, because it slowly happens over time. So the pulse oximeter will be able to tell you whether your oxygen levels are going low or not. And then if you're hypertensive, I would suggest you have a blood pressure machine. COVID has been known to elevate blood pressures in hypertensives quite significantly. And then if you're diabetic, have a glucometer with you to check your sugar levels as well. So COVID also is thought to affect the pancreas and can make if you've got diabetes, can actually make it worse. In terms of the pulse oximeter, before I get into that, why it's also important is how early you come to hospital can also I won't say determine your outcome, but can determine how long you can survive in hospital as well. So if you come when your oxygen saturation is 15%, 20%, the likelihood of you surviving for a long time is very low because a lot of the damage has been done. So having low oxygen is not good for the lungs, it's not good for the body. Free radicals, it damages the lungs. So by the time you come to hospital, it becomes a bit late. So the earlier you come to hospital, the earlier you get oxygen supplementation. The better it is for your lungs, the better it is for your body as well. So someone with an oxygen level of 85% and then gets oxygen is more likely to do better than someone who comes in with an oxygen level of 20%. And then you're basically chasing your tail, trying to recover from the damage that has been done over the past few days. So this is charcoal. Let me check how much time do I have. Okay, this is charcoal. As Seventh-day Adventists, I'm sure we're very, very familiar with it. I think this is the staple drug for Adventists, and its use is broad. Charcoal can be used for anything. As an Adventist, if you're a true Adventist, you believe charcoal can be used for anything. For acne, for whitening teeth, for bloating, for diarrhea, for vomiting, for poisoning, for snake bites, for insect bites, for what else? Yeah, charcoal's for everything. Activated charcoal particularly, isn't it? Yes, activated charcoal. And then, if you go deep into things, you'll even talk about how to make activated charcoal. To show that you're a real Adventist. So I've got a hypothetical scenario here. I've got Mrs. E.G. White. So she's a 63-year-old female complaining of swelling around the neck, which has been there for a number of years, but has recently started causing her pain on swallowing over the past week. Okay, so that's a picture of Mrs. E.G. White. So Mrs. E.G. White lives in the same neighborhood as myself, a Seventh-day Adventist, and as I'm doing my door-to-door activities, spreading the Three Angels message, I come to Mrs. White's home after prayer for help. She explained to me her issue, and after a prayer for help, I offer her, guess what? Some charcoal. I told her, look, this charcoal will absorb the free radicals in your neck, and it'll bring the swelling down, and it'll manage the swelling around your neck. And I tell her to gargle with it. A week later, I come to see Mrs. White, and she's reporting that it's still swollen. It hasn't gone down, but the pain is completely gone. So Mrs. E.G. White was cured by charcoal, wasn't she? Or was she? Hypothetical scenario 2. Mr. J. Bates, 67-year-old gentleman, complains of neck swelling as well for the past 6 months. He says he's lost weight, he's become progressively short of breath, and he lives in the same neighborhood as, guess who? Myself, a Seventh-day Adventist, doing my door-to-door, spreading the Three Angels message. And during my door-to-door activities, I come to his home. I offer him a prayer and tell him to drink a cup of water with 2 tablespoons of charcoal 3 times a day. 2 weeks later, he reports the neck swelling is getting worse and he feels tired during the day. I tell him that, maybe he needs to squeeze half a lemon. If not charcoal, then, the lemon will do it. Half a lemon with the charcoal. A month later, on arriving at the Bates home, I meet Mrs. Bates, and she cheerfully reports that Mr. Bates was admitted a few days ago and died last night in hospital. So the questions that should go through one's mind, and this is practically what can happen. So why did the charcoal work in scenario 1 and not in scenario 2? Was it the method in which it was given? Was it the age of the patients? Was it because there was another underlying disease? Was it because one was gargling and the other one had to drink? Did the underlying disease or condition have a role on the efficacy of the charcoal, that the charcoal actually worked? Did the physiological fitness of the two individuals determine the efficacy of the charcoal? Is it because that Mr. Bates was 67 that the charcoal didn't work and then the other lady was younger? Was it about the charcoal or was it about faith? Did Mr. Bates not have enough faith and Mrs. White have more faith? Would charcoal cure a third individual with a neck mass would be the next question. How many people with neck masses get cured with or without charcoal? So would Mrs. White be cured anyway, even if I didn't give her the charcoal? So if you think about it, these are the same questions that healthcare workers, that doctors, that scientists think about as they treat patients. So you've got a drug, you want to know if this medication or drug you're giving this particular patient is going to be beneficial for this patient with this disease, with these particular complications. And the same thing if you think about COVID as well. So in this particular patient with COVID, or in a group of 100 patients with COVID who have got the same illness of hypertension, will this particular drug make a difference? And it becomes more complicated the more drugs you have. So if you've got 100 people who are on 5 different drugs, each receiving at different doses at different time periods during their illness, how do you evaluate that this one particular drug that you are interested in is the one that's making the difference in half of the patients maybe better? And that's the difficulty with COVID in particular, but also with what we call evidence-based medicine. So you want the evidence. What's the evidence that charcoal works for neck masses? So there are ways of looking at evidence. So we grade evidence according to levels. So there's weak evidence. So weak evidence is evidence that doesn't involve humans. So animal and laboratory studies, they're hypothesis. So there's no real strong evidence, it might not be, but someone in a lab combined a few things and came up with a possible hypothesis, like maybe ivermectin, or let's say one that has been disproven, hydroxychloroquine. Has got antiviral effects. That was done in a lab somewhere, and someone did an in vitro study, and hydroxychloroquine prevented a viral replication. And then they're like, yeah, hydroxychloroquine works. And it was not until later when we did further studies. So you go to stronger level of evidence. So your level of evidence can be observational. So you can just look and see in a group of 100 people. So it would be retrospective. You fly to England and you go into a community and you ask them, how many of you actually took hydroxychloroquine? How many people actually got severe disease? How many didn't get severe disease? That would be more of an observational kind of study. So that's still weak evidence because you don't know what other interventions could have taken place. You're relying on a testimony from someone who might be biased, and they'll tell you, no, it was the chloroquine. So the evidence gets stronger. The more blinded it becomes, the more randomized it becomes. So blinded means that the person that's actually involved, or the people that are involved, don't know who's taken the drug or the ingredient that you're treating or that you're investigating. That's blinding someone. Controlled means that you've got equal groups, the ones who don't receive the drug and the ones who do receive the drug, and so that you can compare them at the end to say, okay, I've got 50 people who have received the drug, and these were their outcomes. I've got 50 people who didn't receive the drug, and these were the outcomes. And that way you can clearly see, is there an obvious difference between the two? And the person who is giving the drug doesn't know who received the active drug and who didn't receive the active drug, and that's called blinding. The only person who knows is a person who's not actually involved in the study, but who will look at the evidence in the end, okay, to eliminate bias. And so those would be your strongest studies, your strongest evidence would be randomized controlled trials or prospective trials where you're looking into the future to see if it really works. And then obviously if you've got systematic reviews. So systematic reviews basically look at multiple randomized controlled trials. So to look at all the randomized double-blinded control studies that have been done in the world, maybe 100 of them, And then it brings them together and then looks at all of the evidence and it says, out of the 100, 50 of them were actually done wrong because of this and that. So a systematic review or a meta-analysis basically brings all the studies together. So if you've got more of those, then that's even a higher level of evidence. And then eventually these get put into clinical practice. Level 5 evidence, part of level 5 evidence is expert opinion. So as a specialist, I can, from my experience, I can say, look, I've seen ivermectin work, but the evidence is still low because I could be biased, essentially. There are many other things that could be influencing the way I'm interpreting the use or the effect of a particular drug. So that's how you basically look at evidence. So if we wanted to know if charcoal works for neck masses, we would get 50 people on our left-hand side who have been selected randomly. So we just went and chose random 50 people that are in hospital who have got neck masses, or 100, sorry, and put 50 of them on one side, another 50 on another side. And then we gave the 50 on the right charcoal without knowing it. And then another 50 we didn't give, okay? And then we see how many patients got better to actually see if charcoal works for neck masses. And it's the same then with all the drugs for COVID that we'll be discussing now. So pre-hospital management. So I didn't go through all the possible medications for COVID because in essence, there's no drug that works to prevent severe disease. There's no drug with good, strong evidence that shows that prevents severe disease, and that's unfortunately the way it is. So there are some ideas and hypotheses that I can share. So the first one is vitamin D supplementation, and this was based on a study in the UK, and they were looking particularly at influenza, and found that the patients that developed severe disease were mainly those that had a vitamin D deficiency. So potentially giving vitamin D, because it also has some immune effects. So it's immune regulation effects. So vitamin D seems to be a sort of immune booster. So a lot of doctors in hospital and out of hospital are prescribing vitamin D, but that it prevents severe disease or that it prevents progression of COVID. There's no good, strong evidence. So randomized control studies, no, there is none. Okay, but we do give vitamin D as an outpatient because it's just a good vitamin to have. Zinc supplementation. So there's early on in the disease, there was an in vitro study that came about. I think it was done in like 2003. Also in vitro that showed that zinc prevented, is it not viral replication, but that the virus didn't enter the cell. It was looking though at the SARS-CoV-2 and I think influenza as well. But no strong randomized control studies show that zinc has an effect in terms of outcomes. So yeah, you're taking it to feel good. Yes. Symptomatic treatment for me, that's where the basis should really be for people who are at home. So it's about feeling well while you allow your body to decide whether it wants to be severe COVID or not. So antitussive, cough syrup. So cough syrup that's not going to make you cough. So there's a tussive that tries to bring out the phlegm, but you actually want to prevent the phlegm because the cough is kind of annoying. It's usually dry, and it just keeps you awake the whole time. You can take Panado for the headache and for the fever. Steaming with eucalyptus or essential oils for decongestion, not that it's going to cure COVID. There's no evidence that steaming prevents severe disease or anything. Don't burn yourself, but steaming does make you feel better, which is good. I didn't add there, I wanted to add melatonin. So melatonin has got immune regulating effects. It also improves sleep. So another symptom that a lot of patients who suffer from COVID have is difficulty sleeping. So melatonin is basically just it's a supplement, so your body naturally produces melatonin when you sleep. So it's just a supplement that you can take that will help with sleeping. And we know sleep has got good effects on how you feel as well. So a lot of it's symptomatic relief. So if you want to have your honey and your lemon to make your throat feel better, do that. If you want to take short walks, do that. Another thing that also makes people feel better is something called awake pruning. So it doesn't improve mortality, it doesn't prevent hospital admission or cure COVID. But what it does do is that it will make you feel better. It'll improve your oxygenation as well. And it prevents atelectasis. So that's collapsing of your small airways. It's 2 hours on your stomach, 2 hours on your side, either side, and then 2 hours sitting up. So we use this also for patients that are in hospital, that are on oxygen supplementation, and it does wonders. You've got someone who's on oxygen or who's on non-invasive ventilation, that's with a mask, and the oxygen levels are sitting at like 80% and 78%, and just like, oh, what can I do for this person? I just ask them to lie on their abdomen, and it goes up to as much as 92, 93%. But yeah, like I said, it doesn't improve mortality. It doesn't mean that they won't need mechanical ventilation, but it does make one feel better, and does improve oxygenation. So there has been some thought that hydrothermal therapy possibly increases the white cell count, it improves circulation and decreases inflammation. So basically warming yourself up, hydrotherapy, but just with warm water. So the articles I saw one in Science, but it was more of it was a hypothesis, not a study. So it was a hypothesis that that it could potentially work in preventing severe disease, and those are the mechanisms that they thought it would work by. But there's no actual study to show that it works. I know Loma Linda was doing a study on it. I don't know how far they got, because this was a long time ago, in April or June or something. They were already discussing how they're trying to get patients for the study, but I haven't seen it being published or anything. So yeah, if it makes you feel good, hydrothermal, don't burn yourself. As long as there's someone watching you, you can try it. But often, yeah, if you're suffering from COVID and you're very sick, it's very difficult to get out of bed, feeling very weak, in a lot of pain. You just want to sleep as much as possible. So some of these things are not possible. I know the steaming makes you feel quite good. So a lot of people would vouch for it. So ivermectin, which has caused much controversy, is basically treats filariasis. Yeah, it's like deworming. So it's sparked much controversy, and it's also based on a in vitro study that showed that it had some antiviral effect at high doses, and I think it was also for SARS-CoV-2. So there've been like a lot of studies. I've seen the ivermectin website. It's like 55 randomized control studies that have been performed. But yeah, a lot of them unpublished. A lot of them haven't been peer reviewed. A lot of them have got like biases and stuff. So the World Health Organization and even the Department of Health of South Africa have both done systematic reviews. So they looked at all the evidence that's been published, that is out there, that has been peer reviewed. So peer reviewed basically means that if you want to publish in a journal, other scientists or other peers who are at your level get to see and look at the stats, look at how the study design was, and if they agree that no, this is a good quality, then it gets published in the journal. So a lot of this, the ivermectin studies haven't reached that level where they've been looked at by others and been peer reviewed. So there's that element of bias that can still be there, bias. So the World Health Organization and the Department of Health both did the independent systematic reviews to consider the evidence, and they reached the same conclusion that the studies were not strong enough to give a definitive answer. So there are studies, but they have some problems with them. So they're not strong enough to say, okay, ivermectin works and we should go out and start using it. And more recently, there was a meta-analysis published. I think it was in the Lancet. I just remember reading it, but yeah, I think it was in the Lancet. It also concluded that the evidence was not definitive enough. So the challenges that we have with ivermectin is the dosaging. For me, that's a major issue. So with the SARS-CoV in vitro study that they did, they were dosing at like 400 milligrams per day. That's like crazy amounts. The recommended amount now that I was seeing in one of some American doctors' protocol was 0.4 milligrams or 0.5 milligrams per kilogram. So if you're 70 kilograms, you weigh like you give about, if you weigh 70, you give about 35 per day. I mean, that's not the levels that the in vitro study were giving for the effect of ivermectin. It was at 400 milligrams. I know someone in one of the hospitals I was working at is giving like 12 milligrams and then 24 milligrams. And I'm like, yeah, but I mean, this is like peanut doses. How do you know this is really working? Because you're not giving the amount that was specified to work. And then at that amount of 400 milligrams, what's the effect of the human body? So those who believe strong in ivermectin will show you some studies that show that ivermectin, even at high doses, doesn't cause complications. Yeah, I don't know. Yeah, there's only potentially eye complications, but also then for how long, the duration in which you're giving ivermectin, those kinds of things. That's why it needs proper studies, because I think we're just, we'll then just be venturing into experimenting on ourselves, which can be quite dangerous. So we just need to be careful about that. The challenge that people are having in terms of doing studies is that too many people are already on it. So there was a study that they wanted to do in Argentina on ivermectin and whether it prevents one from going to severe disease, but they couldn't get enough participants for the control. Control is the group that didn't get treatment because everyone was on ivermectin. So they couldn't actually do a study because too many people were on ivermectin. So that also now makes it difficult. If everyone's already on the drug, how can you determine whether the drug is making a difference? And then the third thing is that multiple interventions simultaneously. So if you're getting remdesivir, tocilizumab, if you're getting dexamethasone, if you're getting ivermectin, you're being mechanically ventilated, how do you know it's the ivermectin that worked? How do you know it's the remdesivir that worked? So that's another challenge now that we'll have in terms of really investigating the ivermectin. Pre-hospital management still. So there's the recovery trial that was done in the UK that focused on dexamethasone and showed that it decreased mortality in patients requiring oxygen treatment for COVID pneumonia. So the steroids, though given early, will tend to more harm than good, okay? So if you give the steroids within the first 5 days when the virus is actually replicating, you are actually allowing the virus to replicate fast and cause more damage. So, and this is just a theory, but if you immune suppress yourself too early, you're gonna cause more damage because the virus then gets to replicate further. So on that, most scientists are in agreement currently that don't give steroids early because you're just going to make things worse. So you want to give the steroids more when the immune dysregulation now starts, when your immune system starts like just going on overdrive and starts fighting itself and causing damage to the lungs, to the heart, to the kidney, to the liver. That's when you want to give the steroids because then you want to dampen the immune response because it's overreacting. Okay, but you don't want to dampen it when it's doing the right thing. Okay, so early steroids is not a good thing. I know a lot of the general practitioners are giving early steroids. So it actually dampens the immune response, increasing bioreplication. Steroids, then hydroxychloroquine, no benefit, definitely out. It was also done in the recovery trial, the Solidarity trial. It fell off very quickly because it actually showed a tendency towards harm. Colchicine, no benefit, so that's a gout treatment. Aspirin, no benefit. Statin, no benefit, pre-hospital. So yeah, not that I'm negative, I'm just, realistic. I think, we just need to be realistic. I think in terms of pre-hospital treatment, it's important to involve a qualified health professional in your care, particularly if you're a high-risk patient and symptomatic. I think you shouldn't do this on your own. It's important that you go see your doctor, and often your doctor will allow you to be calling them and doing video calls and things like that, because they might not be able to come see you. And so that you can check in also daily with them, so that if there are any problems, the sooner you get help, the better. And also you'll be able to pick up the danger signs early. So in hospital management, which I won't go into, we're almost at the end of our talk, and then we can do questions. So the primary goal is to avoid hypoxia or low oxygen. This is in hospital. So it's to put you on oxygen. And then there are multiple delivery mechanisms that we have for that, depending on the patient's needs. And then the final or the last thing we do is obviously mechanical ventilation, because it's the most invasive and has got some complications. But if that is what you need, then that is what you will receive. So yeah, it's different levels, and they escalate according to your need. The secondary goal is to treat any other illnesses that may be making the hypoxia worse. So viral infections cause to tend towards bacterial infections. So if you've got a bacterial pneumonia that's now making your symptoms worse, we give you antibiotics for that. You may develop a heart disease or heart failure if you already had underlying illnesses. So we can treat your heart failure so that you can feel better. If you've developed lung clots, then we can put you on anticoagulation or dissolve the clot if necessary to assist you. So those are the secondary goals. Currently, there are multiple drugs being considered and studied to try and prevent the overwhelming inflammatory response, because I think everyone is in agreement on that. That is thought to be to cause the complications of COVID. So in fact, people are moving beyond the recovery trial. So the recovery trial gave a specific dosage of steroids, 6 milligrams. Now everyone's like in agreement that you probably need a lot more steroids and immune suppression than we're currently giving. So obviously it comes with its complications, but yeah, that's where the thinking is at the moment. I won't go into the other drugs that are being considered in hospital, because I don't think for our talk it's that important. So yeah, I'm at the end of our talk, essentially. Other considerations was just me fantasizing about a time when we will also get to Freedom Day. So this is the UK 19th or 21st July. They essentially dropped all restrictions, COVID restrictions, masks off, no social distancing, restaurants opened. Yeah, let's do this thing. So in the UK, they're free, they're enjoying their lives. They've had their Freedom Day. 2 days ago, Liverpool was playing Osasuna, and packed stadium, Anfield was full, singing "You'll Never Walk Alone," no masks, everybody enjoying themselves. And it's not by mistake, it's not a coincidence, it's not a conspiracy, but yeah, they vaccinated. Yeah, so they're safe, they're protected, they're enjoying their lives, they're moving on. Vaccination, I know, causes a lot of drama and whatnot, and people are twisting and turning in Africa, while Europe is moving along, chugging along. They have their issues, yeah, forced vaccination and all those things, but essentially vaccines do work. Whether the means in which they're enforcing them is another issue. But where the mindset is moving more towards is that because of a lot of the mutations that we're seeing with COVID-19, it will probably not be possible to reach herd immunity that we had always wanted. But if you remember when COVID started, the whole idea was to flatten the curve. The idea was that if the curve is not flattened, then the healthcare system gets overwhelmed. If the healthcare system gets overwhelmed, more deaths from COVID and from other things. So we need to flatten the curve. So we need to social distance, we need to wear masks so that we don't overwhelm the healthcare system. That was the whole thinking of COVID, was to not overwhelm the healthcare system. So now we've got a means of not overwhelming the healthcare system, which is vaccines. So if I give you the vaccine, although I might not prevent you from getting COVID because there are multiple mutations and whatnot, I will prevent you from getting severe disease and from ending up in hospital. So that's what the vaccines do. They flatten the curve. So the UK said, look, yeah, our numbers are still going up. They were sitting at 23,000 cases a day. And they're like, yeah, we're having Freedom Day, masks off. Because the number of hospital admissions had dropped dramatically because people had been vaccinated and protected from getting severe disease. And that's what the vaccine does. It protects from severe disease. So at the moment, it's probably the greatest intervention that we've got for coronavirus from preventing severe disease. So yeah, prevention is better than cure is what we used to say, but it doesn't look like it anymore. So there's not a lot of drugs that work pre-hospital. In fact, yeah, there's no drug that actually prevents you from developing severe disease. Who develops severe disease? There are related or comorbid illnesses that tend towards severe disease. So, which I didn't go into, but an elevated BMI above 30, so obesity, hypertension, diabetes, chronic lung diseases, so COPD, cystic fibrosis, asthma, HIV, definitely, chronic renal disease. So there are quite a few comorbid illnesses that will tend towards severe disease. But even then, there are patients who are massively overweight, that are hypertensive, that don't develop severe disease. So my theory is that there's probably a genetic component to it. And this genetic component probably gets affected by your chronic illness. So it's, your body, the way you are can affect your genes. Also, so the environment can affect your genes and your genes affect you. So I believe that a chronic illness triggers this gene. So the chronic illness causes like a chronic inflammatory state that you're in. So being overweight triggers this gene and then makes you predisposed to getting severe disease. So there are some people who won't have a chronic disease, who will be young, who won't have, who will not be overweight, but because they may have this gene, they will still develop severe COVID. And so we've seen it. So 22-year-old, no chronic illnesses, is not overweight, then develops severe COVID. So I suspect there's probably a gene involved, but yeah, that's just a theory and other considerations, thinking about it. But yeah, thanks a lot. I think then I'm done. If there are any questions, I'll hand over to Connie then to direct us in terms of the Q&A.
Thank you so much, Dr. Chinonge. This was extremely informative. I'm going to go over into the questions now. We've left quite a bit of time for that because in the past we kind of rush and there's lots of uncertainty that people have. Just to also let you know that the vaccine issue doesn't have to become a divisive issue. Each and every person must do as they see fit. If you want to be vaccinated, that's okay. If you don't want to be vaccinated, it's your choice. I have a daughter with cystic fibrosis. Dr. Chinonge just mentioned that. So that is a genetic lung disease, if I can put it in very simple terms, that people with cystic fibrosis are predisposed to chronic lung infections, right? And so they go on intravenous antibiotics every 3 months for 2 weeks. My daughter was vaccinated. She's doing absolutely fine. We had to be vaccinated in order to protect her. So yeah, each person must do as he is or she is convinced. But Dr. Chinonge, I have a question here. Did all the current vaccines undergo randomized controlled trials before being rolled out? That is a question by Brian.
So vaccines went through. Wait, sorry. I'm just trying to think of this properly. So they don't necessarily. So vaccines don't have to go through a randomized.
You just soft, Dr. Chinonge. You're very soft.
Sorry. Am I still very soft? Okay. So vaccines don't have to go through randomized control trials. They have to go through efficacy trials. So we just need to know if they work, if they are effective. So we already assume that not being vaccinated gives you the disease. So we want to know if now being vaccinated means you don't get the disease. So that trial work, it was done, and it did show effect. So if you go to the New England Journal of Medicine, and then just type COVID-19, I think, or vaccines, I think the first one that comes up is the Pfizer, the trial, the study that Pfizer did. So yeah, in fact, it did go through randomized controlled studies. What am I talking about? Yes. So it went through first clinical trials, phasing. So the clinical trials, phase 1, 2, and 3, to make sure that they are safe. And then part of that clinical trials is also to determine whether they are effective. So safe and then versus effective. So yeah, they did go through it, and they are effective. So that's the numbers they're always quoting for us. So in terms of efficacy, they keep on having to redo these randomized control trials because of the different strains that we're getting. So in terms of the original variant that was COVID-19, then you'd get Pfizer would tell you that they are 95% effective. And that's based on randomized control trials. So you get 2,500 people who get it, who get the vaccine, 2,500 who don't get the vaccine, and you see who develops COVID, and then who went on to develop severe disease. So Pfizer will tell you they're about 96% in preventing you from contracting COVID. That was the original before we got the strains. And then there were 98 and 97% in terms of developing the disease and severe disease. So that's Pfizer and Moderna, similar values. The Johnson & Johnson was at a little bit of a lower range. So in terms of developing severe disease, they're also above 95. But they were lower in terms of contracting the disease. So they were sitting at about 80 something. So then you got the Alpha variant, or the South African variant, that brought down the level of Johnson & Johnson and the AstraZeneca as well in terms of preventing disease, or from you contracting the disease. But in terms of preventing severe disease, they've all remained above 90. Alpha, Beta, even the Delta, they still prevent severe disease over 90%. But in terms of you contracting the disease, what we've seen is that they've become not as good as we had initially hoped. Mm-hmm. So Pfizer has dropped down to like 40% in terms of 50% in terms of efficacy against the Delta from you contracting it. But in terms of severe disease, it's still about 90%. So the likelihood of you ending up in ICU, even with the Delta, it's very, very small with the vaccine. So yeah, so it did go through a randomized control trial. And yeah, it passed it, if I can put it that way.
Thanks. Okay, thanks so much for that. And then Palesa wants to know, you've partly answered it, but I think it's good to repeat these things so that just we understand it properly. Does COVID-19 only claim lives of those with serious underlying conditions? Basically, who is at risk of dying from this pandemic?
Okay, thanks for the question, Palesa. So predominantly, it does take the lives of those with comorbid illnesses. So those who have got underlying conditions, and also age, is also a risk factor. So there are quite a few comorbid illnesses. So I won't go through all of them, but cancer, chronic kidney disease. So if you've got those, hypertension, diabetes, and overweight, you've got obesity. So if you've got quite a few chronic illnesses, the risk of you getting severe disease is higher. Your age above 60. But that's not to say that if you don't have this disease, you can't develop severe disease. The likelihood, though, of you developing severe disease is less likely than someone who's got chronic disease. But it's not really possible for us to tell why someone gets chronic, why someone gets severe COVID and someone else doesn't. We don't know yet what is that underlying thing that makes someone get severe disease and someone else not get it. But what we do know is that if you have those underlying diseases, you're more likely to get severe disease and you're more likely to die from COVID than someone who doesn't have it. But we have seen young people dying from COVID with no comorbid illnesses, not overweight, under the age of 30, just in ICU, intubated, being ventilated. And we're just like, yo, yeah, what happened? We don't know, but it happens.
Just today, I heard of a 27-year-old soccer player in Sydney who got COVID. He got married a month ago. His wife went into the room and he had died. 27, he's fit, not overweight, not anything. Yeah. So,
yeah. It's one of those things.
Dr. Chinonge, and then someone wants to know, initial study done on 10 participants with COVID-19 using steam inhalation that show potential to inactivate SARS-CoV-2. So yeah.
Okay, sure. Okay, that's a good question actually. So 10 participants. So if you just look at the level of evidence that we were discussing here, what kind of study was this? It was most likely a case report. Essentially, it's a case report. So it's someone who's reporting on a patient they've treated. So he's got a case and is reporting it. So the level of evidence he's sitting at is about 4 or 5. And so we would then have to evaluate the case report. How is this determined that these 10 people improved? Was there, because there'll tend to be a bias. We're naturally biased towards whatever treatment we think is best, which is normal. So you want to take that away if you want to do a scientific study. You want to say, okay, I want to remove my bias from this. How can I do that? So that would be another question that would go into it. And then the other thing would be, was there a control? Was there another group to compare with that didn't get steam and that didn't do well? So you've got 10 people, I can come with 10 people that didn't steam and didn't get severe disease. So does steaming work or does it not work? So that's why I'm saying, yeah, the level of evidence. So if you've got that, so that's a hypothesis that steaming prevents development of severe COVID. So now you need to build it up, get 10 people who don't steam, get 10 people that steam, and then you've got a case control study, and then you're building up on this pyramid. And eventually you get then a randomized double-blinded control study. And you can then look and really see, does steaming have that much of an impact or not? At the moment, it's, yeah, hearsay, essentially.
Okay, and then I'm just going to read what someone said here. Is it a vaccine or a potential vaccine? The consent form puts it clear that it's a potential vaccine. So why rush for mass inoculation, especially with a survival rate of 97%? What is the main reasoning that procedures should be ignored in terms of clinical trials and approve the vaccine for mass vaccination without long-term effects known? If one has been infected and survived, why are they forcing everyone to be vaccinated with a poorly researched vaccine? Infected leads to, or infection, I guess, leads to natural vaccination.
I think that's why this information sharing is vital, because I see there's not a proper understanding of things. I think sometimes, we hear things through third parties. So with the Johnson and Johnson, so that was where the issue was. So Johnson and Johnson had done their research, just completed it, and they had gotten approval from the FDA, and they came to South Africa wanting approval. SAPRA was not yet convinced because they had just gotten approval from the FDA. So SAPRA says, look, we'll allow you guys, while we're still looking at the evidence that you've produced, we'll allow you guys to carry on doing this under the I wouldn't say the guise, but under the auspice of a study. One, because you're going to be doing this during the time when there's an alpha variant, or I forgot if it's a beta now, the South African variant that's going along, which you couldn't test in America. So we want to see the effect of the J&J against this particular variant. So in that essence, it then becomes a study. Not to say that the Johnson & Johnson doesn't work, because as I said, it does prevent severe disease, it does prevent hospitalization. So it is a vaccine that was working, but because of the conditions at the time, they allowed it to be rolled out as a study vaccine. But that was some months back. That was in January. And the people who did take the vaccine at the time, no one was forced. People who took the vaccine were well aware of what they were signing, and it was put in their faces, look, sign here. And people signed and took it, and it was healthcare workers. I decided not to take it because I wanted the Pfizer, because I was reading and I was like, look, Pfizer is superior than Johnson & Johnson. Why would I take Johnson & Johnson? So I waited for the Pfizer and I took my Pfizer. I don't think anyone is being forced, not in South Africa, at least. No one's being forced, and I doubt it can come to that. With the constitution that we have, I don't think it'll get to that point. There was a second part to the question in terms of natural immunity. So, I mean, and goes back to when this whole thing started. And the whole thing about us social distancing, about the lockdown, was really flattening the curve so that the health system doesn't get overwhelmed. We've always known that, 95% of people that get COVID will be fine. I mean, we knew that from the time COVID left Wuhan. They were already telling us that 95% of people that get COVID will be fine. 5% will need hospital admission. But the challenge was that this virus spreads quickly. So 5% of 7 billion is a lot for any healthcare system, or 5% of 20 million at the same time is a lot. So that's why, they were talking about lockdowns and social distancing and wearing masks, is to flatten the curve so that we all don't get COVID at the same time. We can slow down the spread so that the healthcare system can cope. And that was the whole point of really of us implementing the non-pharmaceutical methods. So now the argument is that, look, now a vaccine is here, which would allow us to slow the spread of COVID even further, allowing our healthcare system to cope nicely. And, this would thus create an environment where COVID essentially becomes like a flu, where, some people are getting the flu, some people are ending up in hospital, some are dying, but it's a very small number that are ending up in hospital. Our healthcare system is not overwhelmed. We're still managing to see the heart attacks and managing to see your diabetic. So, because what's happening currently in the waves is that essentially you stop seeing everything else. It just becomes COVID for about a month or two. And we even are wondering, but where are all the other illnesses? And then as soon as the COVID numbers start to decline now, all of a sudden you just see a spike, and all of a sudden, the diabetics are now alive, and the diabetic foots are now here, the asthma patients all of a sudden exist, and you're starting to see other things. And that's exactly what's happening now at the hospital I'm working at. The COVID side is almost emptying out, and there's an influx on the other side. So that has always been the challenge with COVID, is that people are losing their lives directly from COVID, and also from the whole fear and the health system being so focused on the COVID that everything else gets left behind. So if we can slow the progress or the spread of the COVID, if we can flatten the curve, so to speak, through other means besides social distancing and locking down things, then that is the whole argument of taking the vaccine. But I mean, our talk is not necessarily on that, but yeah.
the talk for this evening, I just want to emphasize, was for us to understand the COVID, because I know it's going to go into vaccines because it's such a sensitive issue at the moment. Someone wants to also know, do we know what the infection rates are in the UK versus South Africa, considering both countries are facing the Delta variant? And knowing this, what are the comparative mortality rates?
Sorry, do you mind just reading that again?
Okay. Do we know what the infection rates are in the UK versus South Africa, considering both countries are facing the Delta variant? And knowing this, what are the comparative mortality rates?
Okay. Sure, those are good questions. I'll ask them to go check. So what they are saying in the UK is that, what did they say? They were sitting at something like 1% in terms of admissions compared to the previous waves. This was at a time when they were having about 23,000 people per day that were getting infected. So we have got, and they were having about 20 people dying per day, 20, and then it was 5 the previous day. So they are reporting that in terms of hospital admissions, they're at an all-time low from the COVID side. So sitting at about 1% compared to previous waves. Their mortality rates are also extremely low. So yeah, I think it's clear. I mean, the fact that they've opened up their economy, I mean, they had completely shut down because they were so concerned. And it's quite interesting. If you look at the UK, their statistics, the majority of people that are dying, they're actually over 80s. So people below the age of 60 dying in the UK are sitting at like 2 or 1%. So they had essentially shut down their whole economy for the sake of their grandparents. I found that quite interesting. So them opening up, and Boris Johnson, their leader, was very open about it, that, we're not going to take chances with the lives of even the eldest in our community, and we're only going to open up once it's safe. And they really feel that it's safe. And their data seems to back them up as well, that the hospitals are not being overwhelmed.
Okay, thanks so much. Dr. Chinonge, someone wants to know, it will go back to the vaccines. What is the incidence of side effects that you are aware of from those that receive the vaccine?
Okay, the incidence of side effects, quite high actually, very high side effects, yeah, a lot, especially with the Johnson & Johnson. So a lot of my colleagues were complaining about pain in the arm, fatigue, myalgia. They say you feel like you've been hit by a train, but it lasts only for 48 hours and then it's done. So those are basically the immune response, and also, the actual direct effects of having the vaccine in your arm that it causes. The more serious side effects, I'm not aware of. I've never treated a patient that's had a direct complication and that I could link it to the vaccine. I was just reading an article before this earlier today that there were 29 patients that had died after receiving the vaccine, and SAPRA was going to look into it. And they've come back to say that, look, it wasn't, about 23 of them were not related to the vaccine at all. And another 5 are still under investigation. So yeah, so at the moment, serious side effects, not much at the moment. You can get an allergic reaction to a lot of the vaccines. Which one is it? The AstraZeneca is the one that causes the clot. So is it the Johnson & Johnson? The AstraZeneca, I think there were like 6 patients in the world that had clots. Yeah, 6 patients in the world that had clots, and so there are some side effects, but like all there's no drug or medication in the world that's 100% safe, like at all, in the whole entire world. Obviously you can take your herbs, but even the herbs, to an extent, some can cause damage if they're taken incorrectly. So there's no drug in the world that we can say is 100% safe and can never cause a tiny thing. So even the aspirin you take, even the Disprin, even the Panado you take, they can all have some side effect.
Thank you, Dr. Chinonge. Someone wants to know, post-COVID, is aspirin effective to prevent blood clots that might happen during your recovery period?
Okay, so that's a good question. Initially, the blood clots in COVID. So initially, I mean, last year April, the blood clots in COVID were underplayed. But over time, there was an appreciation that there's extensive blood clotting in coronavirus. There was at some period towards the end of last year where all patients were basically being treated with high doses of Clexane, which is like a blood thinner. So every patient, if you end up in ICU, high doses. But the evidence has come out to actually say that it's not shown to have a mortality benefit giving high doses of anticoagulation without indication, and actually it causes more complications in terms of bleeding and stuff in the ICU setting post-COVID as well. So there'll be no reason to take it unless you have been proven to have a clot. But in terms of preventing a clot, no, aspirin won't work. It's not its function, so it wouldn't be a wise thing to take. If you are worried about a clot, pray about it. That's a good thing. Pray about it. Essentially, it shouldn't happen if you're still active and you're moving about. It can still happen, and if it happens, it does happen. You go to your healthcare worker, they diagnose it, and they put you on the appropriate treatment. So prophylactic treatment for clots, not really necessary.
Okay. And then we're going to finish at 8. Is that okay with you, Dr. Chinonge?
Yeah.
No, I wanted us to just deal with some of the stuff. How soon should a pregnant lady vaccinate? Yeah.
So that's a very, very good question. I'm not a obstetrician or gynecologist, so I don't know the exact answer. I've tried reading up on it a little bit, but it doesn't look clear to me. They're saying it is safe to take it while you're breastfeeding and doesn't affect the child, but I haven't read the study or seen how they know this. So it's difficult for me to comment on that, particularly those mothers who are breastfeeding. Obviously, if you're not breastfeeding and you've just delivered, then you're fine. You're like the rest of us. But if you're breastfeeding, I can't answer. I'm not sure.
Okay. If possible, please, can you just type your questions in the chat? Someone is asking about ECMO ECMO machines. That's the extracorporeal membrane oxygenation. Do we use that in South Africa? Let me read the question.
Yeah.
Given the advantage of the less invasive ECMO machines, it seems to be used more extensively overseas. Are we considering it more in South Africa to combat COVID instead of turning to ventilation alone? Do you know if we have many of these around?
So ECMO, yeah, extracorporeal membrane oxygenation. So ECMO is very invasive. So it's not less invasive, it's very invasive. So essentially with ECMO, it's a bypass machine. So you bypass the lungs and you oxygenate them through a machine. That way you're giving the lungs time to rest. So it's almost like dialysis, but dialysis for the lungs. So it is very invasive. So there are special lines you put in. There's special way of monitoring it because you don't want the machine to clot. So you have to give them a lot of anticoagulation, and then you need to be measuring that. So it is quite complicated and it's very invasive. There are very few centers in South Africa that have got qualified people that can do ECMO. In the state, there's only, I think it's only Joburg Gen and Groote Schuur. But even then, it's going to be on very select patients because there are not so many machines available. In private, it's used more extensively. Yes, in private, it is used more extensively. It's more available. That it shows a particular mortality benefit, not really. Used early, it makes sense that it would work. And yeah, in Europe, they favor it, but they've always favored it for ARDS particularly. So it works well for ARDS. Yeah, but I haven't really seen the studies that show that ECMO has a mortality benefit. Yeah, but yeah, so ECMO is a lot more invasive and really requires specialist care from the doctor and from the nurses. So you get ECMO trained nurses. Yeah. So yeah, but that's like a higher grade question.
Yeah. And then someone also wanted to know, thank you for that, wanted to know if you are vaccinated, does it mean you won't contract the virus?
If you're vaccinated, will you not contract the virus? You could potentially contract the virus, as you mentioned earlier, particularly the Delta actually reduces your, well, it makes you more susceptible to getting the virus. So it reduces the efficacy of the vaccine. So previously the vaccines were very good at preventing you from getting the virus. But with this new spike mutation, you getting the virus is more likely, but the vaccine still protects you against severe disease, yes.
Okay. And then there's the question about a plant-based diet. Does it prevent you from, do you believe that a pure, let's say, whole food plant-based diet and being alkaline is the best preventative measure for COVID and any other diseases?
Okay, so there was a study I read, NEJM, yeah, JAMA, yeah, in JAMA. I think it was in JAMA. I shared it with someone. So it was a study that actually looked at developing severe COVID, and it was looking at a plant-based diet versus a high protein diet. So a high protein diet is basically eating meat. And they found a tendency towards less severe COVID in plant-based diets. But you still have to look at the quality of the evidence. So there were quite a few number of people that they took into the study. The challenge, though, is what I mentioned before, is that it was an observational. So observational means that they just they handed out basically questionnaires, and then they asked people, are you eating? What do you eat? What do you eat? Did you develop severe COVID? Did you not develop severe COVID? But there are many other things that can be factored into it. So use of ivermectin. So some might have been using ivermectin. That it was observational, so it wasn't a randomized, double-blinded control study. So the strength of the study is not, it's not the strongest. So it is a tendency towards, without saying absolutely that a plant-based diet means that you won't get severe COVID. Obviously, as someone who practices a healthy lifestyle, I would believe that it would, particularly when you look at what causes, well, the theory behind why patients with chronic diseases develop severe COVID, and it's the whole chronic inflammation theory. So someone with hypertension, obesity, they're basically in a state of chronic inflammation through their vessels, and it causes plaques, it causes all kinds of things. So obviously the diet you eat, so if you're eating more fruits, veggies, you're less likely to be in that chronic inflammatory state. As to alkaline and acidotic, I mean, yeah, once again, these are hypotheses. I can't say the hypothesis is wrong, because that's simply what it is. So it's just about developing the evidence. It's okay to come up with ideas, and that's what scientists do. That's what investigating is about, to come up with theories and to investigate the theory. It may or may not be correct, but the way to discover is to investigate it. So yeah, alkaline, acidotic, I mean, I've never really seen anything on that. So yeah, I can't say much.
Someone also wants to know if you are allergic to the flu vaccine, does it increase your chances to be allergic to the COVID vaccine?
Yeah. So the thought is that if you're allergic to any medications, have a tendency towards anaphylaxis, then you're more likely to have an allergic reaction to the vaccine. But even then, the risk is low. So they still give vaccines to such individuals, and just watch them more closely afterwards.
So please, if you have allergies, if you are high risk, if you want to go for the vaccine, go to a hospital. where they then can treat you in case you get an anaphylactic shock. Someone also wants to know, do close people who ended up in ICU had bleeding on the brain, is it one of the COVID complications?
The bleeding on the brain. So it can be a complication of the COVID, it can be a complication of the medication, it can be a complication of the underlying disease. So the COVID can put you in a hypercoagulable state. So you develop clots. So you can get clot in your lungs, you can get a clot in your brain, and the clot in your brain can develop into a bleed. You can also get a bleed from maybe if they're giving anti-clotting treatment, which is at very high doses. So like I was saying, that the move now is towards moving away from high doses of anticoagulation because of the complications. So one of the complications could be a bleed. The third thing is that if the person had underlying diabetes and hypertension, then they may have already had pathology in the brain, and just the stress state of being in ICU could have just pushed them over. So there are quite a few theories.
And there's someone who wants to know, how effective is ventilation to COVID patients, because most of them don't make it?
Okay, so that's a good question actually. So there's in Europe, their outcomes are a lot better than in second world and third world countries. So if you look at Europe, their mortality rate is sitting at about 25-30% for COVID patients that end up in ICU. So 70% of their patients survive. In Africa, there's a recent study that was published, I think it was last month or the month after that, that showed we are sitting at 50%. And it depends on which hospitals you're talking about. So they were looking at tertiary hospitals in Africa, and they're looking at the better hospitals. So I suspect it's a bit worse than that. And also, what is the second thing I was going to say? And also, they were not determining whether this was during a wave or not. So I think during a wave, mortality rates actually go up because the healthcare system is overwhelmed. And then once the wave goes down, mortality rates improve in the ICU, but we're sitting at about 50%. So 50% of people that make it to ICU will roughly not make it. But obviously it depends on other things like their underlying physiological status, their comorbid illnesses, how soon they came to hospital, those kinds of things. So there are quite a number of factors that are involved in it.
Okay, thank you for that. Someone also wants to know, they have lupus, SLE, and they want to know, would being vaccinated, is it a good idea? And if yes, which one would be best?
So if you've got lupus, definitely please get vaccinated. Sure, because lupus can be complicated to treat, and you don't want COVID, and sure. So please do get vaccinated if you've got lupus. At this point in time, there's no particular vaccine. It looks like all of them will need boosters at some point. I still just have a tendency towards Pfizer. I don't know if it's my United States bias or not, but J&J is also from America, but Pfizer and Moderna were done by like the US Army. So I still have a tendency to favor Pfizer. I think in the end, we'll still find that it's quite a superior drug. There's talking of mixing vaccines and so forth. So at this point in time, I'll just say whatever vaccine you can get your hands on, use it. I don't think we really have a choice in terms of selecting vaccines at this moment. I think possibly by next year, the supply will be so much that we'll actually get to choose which vaccines we want and just walk into a discount and just get the shot. I think the world will be heading towards that point by next year anyway. So I'll just say, any vaccine you can, please do get. If you're lupus because you're on immunosuppression treatment, get vaccinated, and you know you're safe from severe disease. You won't be going to an ICU for COVID, and it will give you a lot of peace of mind.
Okay. Thank you so much, Dr. Chinonge. We are going over time. It's 8:01, and Dr. Chinonge is on call. Thank you so much for your time. We really do appreciate it, because I think we can just go on and on. There's so much that we don't know, that we'd like to know, that we are unsure about. But I would like to thank you for your time. We can, oh, sorry, I'm so sorry. Someone is saying a question on fertility. I did see it. Hi, Dr. Kay. There's a lot of information going around that there's possibility that vaccines have potential of causing infertility. Is there any information or truth regarding this? Also, before Dr. Chinonge answers, please understand we can't take all the questions. I'm trying to see the ones that will be most beneficial to people,
Everyone.
to everyone. So, Dr. Chinonge, if you can just share your information on that, and that will be the last question, unfortunately,
Okay.
because we can't go on and on. We have to respect one another's time. Thank you.
Yeah, definitely. Yeah. So I just wanted to briefly, I saw quite a few questions as well. Yeah. So there's a lot of questions that, I won't manage to get through, but just going through some of them, and then I'll come to the infertility one last. Someone was asking about immune boosting and why is that not being spoken about? And the fact is what we discussed earlier. There's no evidence to show that a particular thing boosts the immune system well enough to prevent severe COVID. So as I mentioned, you can take your vitamin D, you can take vitamin C, you can take thiamine, but none of these things have been shown to prevent severe COVID. So there's nothing that has got strong evidence to show that. So it's difficult now to say, okay, now, boost your immune system, it works. So there's no point emphasizing that if there's not really much that can be said about it. I mean, another person was speaking about why not emphasizing healthy lifestyles. I think it's beyond this presentation to now talk about the benefits of exercise and how much weight you'll lose and, diets and the different types of diets. Then we're just going to be going on forever. So I think we needed to get a scope. As Seventh-day Adventists who are practicing the health message, I mean, I can't preach to the converted, can I? So there are certain things I wouldn't manage to go into. And then others were asking, or were just concerned about the vaccine. And I think one should be concerned about the vaccine. I was very concerned about the vaccine when it came about, how quickly it was made, the science that was behind the vaccine as well. Definitely it is a concern. The third thing is that we don't know the potential long-term outcomes of the vaccine. And the fact is that we can't, because I mean, we haven't lived 10 years with the vaccine in our shoulders, in our systems or whatever. So we don't really know what the potential outcomes will be in 10, 15 years from now. Okay, so that's it. Yeah, that's the fact of life. But the acute or the immediate complications we do know. So there's no fluffing about it. Are the vaccines safe? Are they not safe? That we do know. The reason we know this is that governments have made getting the vaccine for COVID a priority. Mm-hmm. So they've basically put all their money into it. They've put all their time into it. They've put billions. So it hasn't taken 10 years. Yes, it's taken 12 months. So that's because everyone was focused on it. And that's just a marvel. So it just shows you what we can really do as a world when we put our mind towards something. And it's a shame that as Africans, we're still very suspicious and, as usual, the Europeans are running, their economies will get up to speed sooner than ours. And, as usual, the Europeans will have the advantage over us because, they're just ahead of their time. The Canadians have got stocked up enough vaccine to vaccinate their country 4 times over, So they're not in any doubt, that, this thing doesn't work or does work. The Israelis have already started giving out booster doses in their country. But yeah, while we deal with our superstitions, it's fine. We will be patient. Everyone's got the right to view things as they think, which is not a problem. In terms of infertility, there's no evidence that being vaccinated causes infertility in the short term. So in 15 years, 20 years from now, maybe there'll be a study that comes out to say that, if those who got vaccinated can only had 1 child and not 2, or didn't have children, time will tell. We can't say what the outcomes of the vaccine will be in 20 years' time because we haven't lived we can't go into the future and see what will happen in 20 years' time. So yeah, we can only live in the present by faith. But yeah, if you are concerned about it, if you're at that age, the other option is maybe just have your children now and get vaccinated and not worry about it in 2 or 3 years' time. But yeah, that's it. Thank you very much.
Okay. Someone also just asked, why don't they test for antibodies before being vaccinated?
Sorry, yeah. So I there was a time I was thinking about that. Why was I thinking about that? There was a study on it recently, and they were trying to look at whether if you had antibodies, whether you needed a booster or if you didn't need to get vaccinated, or if you only needed one shot. Yes, that was it, a UK study. So the UK study, because the UK was trying to see if they can try and kind of spread out their vaccines. So maybe those who have had COVID and have had antibodies would get just one shot. Mm-hmm. It just makes it complicated. I was discussing with someone the logistics of having to test everyone in terms of their antibodies and then deciding which ones. I don't think our health system can at this moment bear with having to do. Imagine how long the queues would be. You know, people would have to return again after all of those antibodies. So in the state, it wouldn't quite work out. I think it is a good idea, because if you had antibodies, depending on the level, you either get a booster, or if your levels are high, then maybe you don't need the vaccine at all, kind of thing. Yeah. Okay. But yeah, it just wouldn't work out in terms of practicality of it.
Okay. Thank you so much, Dr. Chinonge. We know we have Dr. Benenge on here as well. Dr. Benenge, do you want to add anything? We've got Dr. Laguno as well from the SID. If you want to add anything, you are welcome to do so. You can unmute yourselves because you have co-host status before we end the program. Okay, then I take it there is nothing further to say about anything. Dr. Chinonge, once again, thank you so much for your time. Thank you for all the information. We will try and arrange more sessions like these, because there's so much uncertainty and around the topic. There's so much people are wondering about, and often people don't know where to go. And so that is why we have created this session, so that questions can be answered, information can be provided, and you are more than welcome to send suggestions on what you think needs to be addressed. The doctors can tell us, the members can tell us. We are open to arranging these sessions. And thank you all for attending. Thank you for your time. We had quite a few people on. A lot of people have left, but we are still having quite a few people who are interested or stayed until the very last. And thank you for attending. Thank you for your time. Thank you everyone who assisted. And I'm going to ask Pastor Denzel Fourie if he can please close for us in prayer. And if I may, Pastor Fourie, if I can just ask you to also pray for people who have lost loved ones now with COVID. There are people on the session present who have lost close relatives, and I guess it is something, you know, that affects all of us. So if you can just bear our members up in prayer as well as our health workers. Thank you so much, Pastor.
Thank you, Sister Conning. Brothers and sisters, I invite you to bow your heads and close your eyes with me as we pray. Heavenly Father, we thank you for the presence of the Holy Spirit among us. We thank you for your guidance in the presentation. We thank you that even in the questions and the addressing of the questions, we could sense that God is at work. But Father, during these difficult times, we want to thank you especially that we are still in the land of the living. It is such a blessing to be alive, and for that we are grateful. Many of us have been touched by the cold hand of death. We have lost folk close to us. And we pray that your continuing comforting presence would abide with us, and that daily you would give us fresh supplies of grace as we continue this journey homeward. We ask that the love and compassion of Jesus would reign supreme in our hearts as we traverse through this difficult season. We pray, dear Lord, that you would grant wisdom to those who bear the load of making difficult decisions, decisions for our country, decisions relating to remedial action, decisions which even affect our worship and our fellowship. Please grant them much wisdom. We pray that you would impart healing to those who are suffering, and that you would provide strength for those who are caring. We commit to you those among us who are more vulnerable, and ask that you would give strength so that they would not succumb to the risks of this virus. And then, dear Lord, especially do we pray that you would curb misinformation. Misinformation which comes our way and causes unnecessary fear, and which causes us at times even to lose control. You've given us brains. Please grant that we would evaluate what we hear, that we would exercise good sense, that we would exercise caution. But most of all, we pray that you would give us grace to approach each day in faith and peace, and to trust your goodness, and to submit to your sovereignty. Oh Lord, we thank you for your goodness and your mercy and your grace. We thank you for the time and the effort and the knowledge and wisdom of Dr. Chinonge. We thank you for the ministry of Sister Connie, and we ask that you would continue to bless them in your work as you use them to bless your people. Dismiss us now with your blessing and watch over us. In Jesus' name we pray. Amen.